here. Welcome to our Interprofessional Student Showcase. This is for spring 2023. And this semester's presentations represent collaborations between two universities with 53 students from 13 different programs and professions. And what they're going to do today is share critical takeaways from a range of immersive collaborative learning experiences across UNE campuses and Rosalind Franklin campuses on virtual platforms and in the community. And I just have to say, I've watched all of them. I'm so extremely proud of all of our students who are presenting to you today. This day also gives me an incredible opportunity to thank people who have worked so hard this year for CC. This is sort of the culmination of our semester efforts. And so, of course, I want to thank our incredible staff, Chris Hall, Michelle Cody, and our intrepid evaluator, Kira Rodriguez. All of us together have worked hard this year, and they're amazing. I want to thank Lee and Dave, who isn't here with us today, but has done amazing work. And thank you, Nate, for joining us today. You not only make these virtual events possible, you make them perfect. So thank you so much for that. And I'm very sad to be saying goodbye to some of our graduate assistants. It just kills me. I think you should stay one more year. Thank you so much. And I want to just say thank you to all our faculty who give so generously of their time to CC and our interprofessional efforts, and to our advanced students who more and more are contributing to our initiatives. So it's now my delight to introduce Provost Gwen Mahone, who's going to make the opening remarks. Gwen?
Great. Thank you so much, Shelley. I am just delighted to be here. I've looked through the lineup and the different presentations that are going to be on today, and I'm just so impressed and so much looking forward to watching them and listening to you. I also want to say thank you, of course, to Shelley and Chris and Michelle, but also to the graduate assistants and to communications team who worked on here as well. Everybody who's made this possible. I really appreciate it. And again, I'm so impressed and excited to hear the presentations. Before I joined UNE, where I now serve as the provost here, I served as a dean of a health profession school for a number of years and an associate dean in a medical school. So for many, many years, over 2 decades, I have been a big supporter and been very passionate about IPE and IPP. And I just know how important it is to work as a team in anything that we do in life, but particularly in healthcare, working together as a team, respecting all the professions, understanding the scopes of practice of the different professions, how we can learn from each other on an ongoing basis, and having a shared language, that we work together in, just makes such a tremendous difference to the patient, to the client, in really working with them also as part of the team in a holistic way and a very human way. And as I look through the titles and little summaries about the different presentations today, I can see that that's there, front and center. And so I really want to congratulate the students for understanding the importance of that and having the vision to see the importance of that. And I'm just thrilled that when you leave UNE one day and go out to practice, that you have this experience. And I really hope you carry this through in the rest of your life as you continue to be a practitioner and a learner, and that you continue to understand the importance of learning from each other and working together. So I'll leave it at that. As you can see, this is an area I'm very passionate about, and I'm just so excited that this is a really important central theme in our education at UNE. And again, want to congratulate the students for what looks like some very impressive work. So thank you, Shelley.
Thank you, Gwen. That was fantastic. So this is another exciting part of our poster session. We in 2015 established the M. Lisa Pagnucco Award to recognize faculty and staff who had been major contributors, given graciously of their time and their brains and their efforts to advancing interprofessional education and practice here at UNE. And so I'm going to announce winners. We couldn't pick one this year. It's always hard to pick even two, but our winners this year are Jan Froelich from the Occupational Therapy Program, who is retiring this year, but we know where you live, Jan. So we will be asking you back.
Okay.
And Mary Obie from the Dental Hygiene Program, who has given and dedicated such amazing opportunities and information to all of our programs. So I'm going to introduce Mary first, who is going to say a few words, and then she'll pass it on to Jan.
Great. Thank you so much. I am so honored and proud to have received this award. As Shelley has said, I am the Mary Obie from the Dental Hygiene Department, and I actually have to thank Chris Hall for getting me into this over 8 years ago, sitting on the front lawn, and says, Mary, you have to get dental hygiene involved in this interprofessional education. I was like, great. Didn't know what I was getting myself into, but now I'm just so passionate about it. I've been able to, get to meet a lot of colleagues and share the passion that I have for dental hygiene. And not only do my dental hygiene students learn about all the other professions, and I've learned a lot, I learned a lot every time we get together, but also the dental hygienists, they are letting other people know how important we are as a healthcare team. So there's a lot of collaboration now between different professions at UNE West College Health Professions, as well as other professions. And we're just so proud, and I talk about it. I do a lot of accepted students days. I get to work with freshmen, sophomore, junior, and senior dental hygiene students, and I tell everybody to get involved. And I'm just so proud that I've been recognized for this. It's just a passion, and I want to thank Chris for that. And I want to introduce Jan Froelich as my colleague award winner.
Thank you, Mary. I'm also thrilled to be receiving this award. I've been at UNE for almost 34 years, and doing interprofessional work has been at the center of my time here. It's a great passion of mine. As you all know, we live in a very beautiful and a very hurting world, and we need each other to solve the complex issues that we face. We need each other across all the divisions society has placed upon us: gender, race, class, culture, age, disability, sexual orientation, religion, and more. And we need each other across professional lines. As I said, as OT faculty at UNE for 3 decades, it has been a great pleasure for me to learn from, with, and about interprofessional teams of faculty, students, staff, and clients from diverse backgrounds. Working together, we have reached for and developed solutions to many of the challenges we face in health and social care. And of course, there is much more to learn and do. But in well-connected and diverse teams, we are unstoppable. As I near my retirement, I'm deeply honored to receive the Lisa Pagnico IP Service Award for my contributions. Thank you, everybody.
I have my proud face on. I wish there was a proud face emoji, but thank you both. And thank you for those wonderful words. And we do grab people off the street to join us. Thank you, Mary. And so now it's my honor to pass it on to Chris Hall, who will describe how to proceed today.
Thank you, Shelley. And Jan, we will miss you. And Mary, I look forward to more shenanigans in the future. So today we're happy to present 13 presentations over 3 breakout rooms. The breakout room dialogue box will open for you very soon, but you have the brochure available to you in the chat. Please download it if you want to use that to follow along. The first track is presentations that show leadership, which is one of the interprofessional competencies. The second track is dedicated entirely to the interprofessional team immersion. If you want to learn more about that, there's no better source than the students who have just been through it. We welcome you to check that track out. And the third track is a public health focus brought to you by faculty Ling Sao and Kin Lee from the College of Osteopathic Medicine. They have some great student presentations there for you. The live stream and Facebook will follow diagonally through the program. So you see the highlight areas, those will be live streaming out to the web as they're happening, and all the others are available. You can move around within the Zoom atmosphere as much as you like, so you can bounce back and forth. You don't have to stay in one track. I'll be out in the main room, happy to answer questions if you have any as we go forward. So Nate, if you want to go ahead and open up the breakout rooms. I hope everybody has selected their favorite track, and we'll take this opportunity to travel there.
Welcome, everyone. I'm Sarah Garber. I'm going to be the facilitator for this track. We'll get started in just a minute. I think we're ready for our first presentation.
We are presenting our interprofessional student-led mini-grant project titled Supporting Health with Harm Reduction, Cumberland County Jail Wellness Bags. This project is an interprofessional collaboration between UNE Occupational Therapy, Public Health, Dental, and Medical students, the Center for Excellence in Collaborative Education staff, UNE faculty, and Cumberland County Jail, also known as CCJ staff. The aims of this project include creating 200 harm reduction kit bags to support the re-entry of residents departing CCJ, and 75 wellness bags for.
Some data that informs our project is estimated that 1 out of every 2 residents re-entering the community have mental health concerns, with 2 in 5 men and 3 in 5 women report having a combination of physical, mental, and substance use disorder. Within the first 2 weeks of re-entering the community, those with SUD are 120 times more likely to overdose than the general public. 2021 saw a surge of overdoses in Maine due to the rise in fentanyl, with 77% of the 632 confirmed overdoses being caused by fentanyl or fentanyl analogs.
The wellness bags include a range of supplies as seen on this slide, from toothbrushes, socks, notebooks, and bus passes to harm reduction items. The harm reduction items include Narcan, which can reverse an opioid overdose, fentanyl test strips to test substances for fentanyl contamination, and resource packets. The packets have locations and contact information for needle exchange programs, recovery centers, shelters, medical and dental care, employment opportunities, and helplines.
In order to pack these bags, we had a student-led event where we would meet with the corrections officers at the Cumberland County Jail, and we would pack these bags with them. Every bag is identical with the stuff that was in the previous slide. And then we also had an event where we would pack correctional officers' bags to promote their health and wellness.
Our future plans are to continue to strengthen relationships with the CCJ staff, to retain and update the resource packets and the mini grant information, and to follow up on how to improve the harm reduction kits with readmitted residents.
So funding for this project was provided by the Center for Excellence in Collaborative Education, also known as CC at UNE. And we also want to thank the Cumberland County Jail for allowing us to have this experience. And I have a list of people and organizations that donated to this project, and also a list of people that helped us and guided us through this project.
Thank you very much for an excellent presentation and a wonderful project. Are there any questions from the audience? If there are presenters from this team, please identify yourselves also. And I think Dr. Cohen Conrad has a question.
So thank you. And obviously I've been through this with you folks, but I'd love for you to talk a little bit about why you decided, because a lot of programs around the country do bags for people transitioning out of correctional facilities, but you really focused on correction officers. And so I'd love to hear a little bit about that decision and some of the input you've gotten about that.
I can start with that. So we kind of focused on both the correctional officers and the residents. Like you said, And I think a big part of that was just because we wanted to get as much input from these correctional officers as possible. So meeting one-on-one with them and like allowing us to like facilitate those conversations and making it known like how important harm reduction is, handing out flyers. We've talked a lot about how the vision of like the correctional systems have changed so much. And so we learned a lot about that we learned a lot from them on how they've been able to change it and what they're going to change. And it can inform like our future in this mini grant in allowing us to continue the harm reduction kits.
Thank you so much. I think we have a question from Dr. Sheldon.
Yeah, good afternoon, everybody. My name is Mike Sheldon. I'm the Associate Provost for Academic Affairs here at UNE. I've learned a lot from my mentors, folks like Jan and Shelley over the years, that this engagement with community partners like the Cumberland County Jail really need to be sustained in order to be meaningful. It's like not just going in once and out and this never happens again. So Macy, I think in her remarks, talked about the future and hoping to strengthen further engagement. I have some experience from the past. I used to be director of the physical therapy program here, and we had some programming over there. So I'm really interested in your thoughts about the continuation of this program into future years, as well as any other thoughts you have about how else you might engage with the population over there.
So my name's Julia. I'm one of the other members of the Harm Reduction Kit project. We like twofold answer. One, we have applied for a United Way grant, and that would provide a much larger sum of funding than we get from the CECE office. So if we do get that, which we'll hear back from in about a month or two, that would be substantial and could definitely provide funding for several years. And then in the meantime, we're definitely looking to just continue with the CECE grant. And that is something that we continue to discuss of how we are going to continue these efforts, as it's not sustainable just to use the CECE money every year.
That's excellent. It's really exciting to hear about this type of a project, and the potential of continuing it for long term is really impressive. So thank you very much for your efforts and the support of the community and the interaction between you, the students, the institution, and the community. I think we've got about a minute before the next presentation starts. Are there any final questions? Oh, yes, Dr. Husband.
Hi, thank you. Such a fabulous project. I was wondering about the experience of actually sharing the kits, what that was like as a student team to have that experience of fulfilling the project and sharing the kits.
And if we could have a very short response to that.
We didn't actually hand out the kits. We just filled them with the team, but we were able to hand out the correctional officer ones, and they were very happy that we were able to do that and like felt very appreciated, which we think will like transfer over to them handing out these harm reduction kits.
Thank you so much. And with that, we'll start transitioning over to our next presentation. Our next presentation is going to be from Impact of Leadership Roles in the Interprofessional Telehealth Approach to Long COVID Treatment by Kara Lattes.
Hi, everyone. My name is Lindsay Bollier. I'm a UNE DPT student, and we're presenting today on the impact of leadership roles in an interprofessional team.
I'm Marissa Carbone. I am also a second-year DPT student at the University of New England.
My name is Caitlin Coates. I'm a first-year medical student at UNE.
My name is Karen Godney. I'm a master's social work student at University of New England.
And I'm Amber Haas. I'm a physician assistant student at Rosalind Franklin.
We did our experience with the Interprofessional Team Immersion Program, and that was with Amanda and her husband, Mo. Amanda is struggling with long COVID. We met with her through telehealth, and as a team divided up interview time to each person to give an appropriate amount of time to get all the basic information. And the experience led us to want to look into leadership and how it's viewed and taught among different professions.
The leadership role of a physician assistant and a doctor of osteopathic medicine are often the first point of contact a patient has when there is a concern.
Both of these professions oversee the treatment plan and coordination of professional healthcare staff to ensure the patient is receiving the best care possible. They're also an important educational resource for patients, their families, and support staff during diagnosis and treatment of every patient.
We're also the ambassador for these patients, which helps eliminate burden caused by balancing multiple specialties and visits.
Physical therapists are not often seen as leaders, and our leadership really varies depending on the setting. You can look at, we are referred as related service providers in the school setting, but we also have the ability to be direct access providers in other settings. It's important to realize that collaboration is emphasized to the highest regard because we rely on other healthcare professions to give us information, and they rely on us to give them information. Leadership is really important and is emphasized as a key competency in our program.
Social workers have historically not been in leadership positions, partly due to gender discrimination as well as distorted cultural values. There's little focus on leadership skills in school programs. In the NASW Code of Ethics, we're obligated to uphold and advance social work values. Social workers approach leadership from a systems perspective, hence the field lends itself easily to an interprofessional approach. The interplay of relationships is key, which is what we found during the simulation. Leadership roles are very important to establish when working as an interprofessional team, and they may differ depending on the patient. The most effective interprofessional team is one that understands each other's strengths and weaknesses and meets the patients where they're at.
Just to end, we wanted to quickly thank our faculty facilitators as well as our peer facilitator. Thank you for watching.
Thank you very much. That was an interesting presentation on leadership and interprofessional leadership. Are there any questions for the team, the Carolates? Dr. Jan Froelich, do you have a question?
Yeah, I was curious, how did the leadership play out on your team? You spoke about, how social workers and physical therapists aren't often in as much of a leadership role and some of the factors involved. How did it play out as you functioned as a team?
I can speak to this. So this is why we decided to do this as our presentation, because we actually had a really hard time finding somebody to be a leader on our team. Nobody really stepped up right away. And so we kind of floundered a little bit, and we were trying to figure out where we all fit in. And I think we didn't want to step on each other's toes. And so nobody came out as a leader right away. And so that was like an interesting dynamic with our group and why we decided to do this presentation.
Did a leader eventually emerge, or was it more of a collaborative process? Usually a group needs a leader. Sometimes that they're not even called the leader, but somebody's really got to kind of take charge and think about the whole. So what happened around that?
I can speak to that, Marissa, if you want me to. I really feel like it was really interesting in the interprofessional way that we all ended up being leaders in a way, and we all were just really listening to each other, and we gave respect to each other, to each our own professional expertise, and that each of us had a time to shine, and we really let each other step forward when the person was, when you're on, it's like, okay, it's your turn. It ended up flowing. We floundered and then it ended up flowing.
Sounds very organic.
Thank you. I'm sorry, go ahead.
Oh, I also wanted to add on to what Karen said. I think the leadership roles changed once we got to know our patient Amanda and really understood what her specific needs were. So I feel like myself and Caitlin, who are more like medically knowledgeable, and that's like the basis of our education. We started off leading Amanda in her appointment, but then when we realized that she really needed more kind of like emotional support, that's when Karen became the leader, and then Marissa and Lindsay also helped and stepped up to provide a more of a holistic out view of how we could feel better.
Thank you. It's wonderful to hear how flexible you were.
Yes, it's fascinating, isn't it? The term I've heard for that is called fluid leadership. That the person in the profession steps up as needed and then hands off as needed. And it sounds like your team's experience was a perfect example of that.
What did you learn about one another that might have been most surprising about each other across professions? What kind of stood out, or didn't you know ahead of time?
I think for me personally, I really realized how powerful the role of the social worker can be in advocating for and helping the patient understand what their needs are and how they can have their community support them. So that was not something I had experienced prior, and I think it was really important to see that.
I really appreciated my fellow team members being, we really appreciated each other, I think. And we really understood what each other was doing eventually, and respected each other's roles. And I think that's super important.
Sounds like you all brought a bunch of humility to the team. Yeah.
That's exactly the word. That's the word I was looking for. Thank you.
And respect. Yeah. Thank you for sharing that. Just lovely to hear about your process.
I look forward to having you all as practitioners.
Yes.
Okay, thank you so much for that presentation and the humility with it. We're going to start moving to our next presentation. And this presentation is going to be Interprofessional Long COVID Migraine Management via Telehealth by the COVIDosaurs. Excuse me.
Newer complex conditions like long COVID have yet to be fully understood and often require thinking outside of the box. Our team of interprofessional students developed a plan that incorporated multiple disciplines to create a holistic approach for migraine management in a long COVID patient. Our team tackled the Interprofessional Team Immersion Project, a telehealth clinical simulation experience.
Our student team consisted of Emily Blackwell from Occupational Therapy, Erin Kim from Allopathic Medicine, Dana Megan from Physical Therapy, Macy Funzlan from Dental Medicine, and Ashley Roy from the Physician Assistant Program. We would also like to acknowledge the support we received from Professor Denise Blaze, Professor Kristen Columbus, and social work student Sarah Kelly throughout this process.
The main challenge of this experience was to develop a comprehensive strategy that incorporated both pharmacologic and non-pharmacologic methods to meet the specific needs of Amanda, our telehealth patient, and her family. This is important as it teaches us how to collaborate between different professions and navigate patient-centered care through the added obstacle of telehealth.
In this simulation, we met Amanda Barry Mantell, who is a 39-year-old woman who suffers from long COVID. Our telehealth appointments focused on her chief complaints, her most prominent and debilitating one being incapacitating migraines. Amanda preferred non-pharmacological care, whereas her spouse, Mo, requested pharmacological options. Taking into account our patient and her family's priorities, we crafted a multidisciplinary approach to her care.
The suggestions our team came up with for the care of Amanda included pharmacology, relaxation strategies, osteopathic manipulation, nutritional counseling, and environmental modifications. These wide-ranging strategies allowed us to meet the complex needs of Amanda's diagnosis. Through this experience, we learned how effective interprofessional collaboration can be utilized to improve patients' quality of care. Thank you for listening to our presentation.
Thank you so much. Very interesting presentation. I'll get started. We heard in the last presentation about leadership, and I'm wondering, how did your team experience leadership? How is it handled within your group?
I can talk about that. So for our group, we kind of assigned one person as our point person that was going to be constant throughout every single session. So that way Amanda had a familiar face and like instantly someone that she already had a connection with, as dental students, PT, OT, medical, everyone came in. So Ashley was our PA student, so she kind of tackled that role. And then we all just kind of tried to collaborate around that while having her as our point person.
Dr. McCormick-Tutt, you have a question?
Yeah, great presentation, you guys. It sounded like you said her preferred treatment was not pharmaco. And yet that was one of your treatment options. How did you approach that with her to say, we know this isn't your preferred, but this is still one of the options we want to provide you?
I can also talk about that. So we tried to present her with pharmacological options that were much more on an as needed basis instead of a daily medication. So that way she felt like she had more control over if she was going to take them as not, just to give her as many options as possible to get some relief and be able to carry about her life better. So that was just the main goal, was to make her feel like she had as much agency in her own care, especially around medications.
And just a follow-up, did you get to do any follow-up with her after creating the treatment plan to see what she decided to use and if it helped?
We did a little bit, but because of time constraints, we didn't get as much of that as we would have liked to.
Great. Thank you.
I have a question about what kind of environmental adaptations were recommended for the client.
Yeah, so from an OT perspective, I was looking a lot at her like environmental context and ways that we could adapt it to help her engage mostly at work. She complained a lot about headaches at work and just really struggling to get through the day. So we discussed just implementing breaks throughout the day and trying to advocate for her needs to her boss, which they discussed not always being the easiest thing to do. So we also thought that collaborating with social work could be a good idea to establish accommodations that could really help her advocate for her needs in the work setting. And I think if we were to go further, it would have been interesting to figure out how we could adapt her home environment as well. She did have like a calm space that she could go and take breaks in at home too. So I think just integrating that into her daily schedule could be really helpful.
And just as a follow-up, how about, you mentioned relaxation, like what types of relaxation techniques seem to be the most effective for her?
Yeah, so we found a variety of options. We recommended different applications that she could use and also YouTube videos that were kind of specific to meditation for migraines, and just really try to find ones that were easy for her to access and use. In the first session, we recommended that, and then we followed up in the next session and asked if she had been able to try those out at all, and she had not. So we just made it more clear. We kind of developed a list and ways she could access those sites. So hopefully she would use them going forward.
Great adaptation.
Absolutely. Good sensitivity to the patient. Lots of empathy there. I wonder, with the telehealth format, did it help or hinder being able to sort of have some insight into her environment that you could actually see, or was the platform difficult to use? How did people feel about that?
For that, she was stationary, so we didn't really get to see around her environment. I do think if we had asked her to move around or show us her space, that might have been helpful. But again, we weren't as focused in the moment on her home environment, although that was something, like Emily said, that we would like to address in the future.
Since we have time, I'll ask the same question again. Was there anything you learned about one another that was surprising about each other's professions that you didn't have an understanding of before working together as a team?
On our team, we had a dental student, and I just didn't realize like how vast of knowledge that dental students, what their education consists of. Our dental student, Macy, focused a lot on improving the patient's diet, and just they're focused on oral care. That was all super new to me, because when I think of a long COVID patient, I definitely don't, the first person I picture is definitely not a dentist, but your oral health really plays a huge role in your overall health. So I definitely learned a lot about dentistry.
Also on our team, we had 2 DO students, an MD and myself as a PA. So we had a lot of overlap as well. And I think it was really great to see
how we all could contribute and take different aspects of the patient care. So I was really proud of how our team overall worked together and divide up the tasks and all have an important role.
Sounds like it was a really great experience. There are no more questions. I think we'll thank you so much for your presentation and move to the next one.
Nice seeing all of you.
And this next report is a collaborative case report on providing interprofessional holistic care by the Holistic Helpers.
Hi everyone, we are the Holistic Helpers, and today we're presenting a collaborative case report on providing interprofessional holistic care. Our patient is a 39-year-old female presenting with long COVID. She was hospitalized for 11 days in 2020-21, and her primary limitations include migraines and fatigue. Her health team is located 55 miles away from her home, which is an important detail to note. And in order to get back to her normal routine, she was interested in alternative approaches to medicine. And so we used the following care team members to provide a holistic approach to care. And here are Kleiman's 8 questions for cultural assessment, which provides us with a better understanding of what our patient is hoping to get out of her interventions.
So we decided to do some examples of a holistic care in medicine. We discussed with our patient acupuncture and medicinal medicines such as marijuana to reduce pain and frequency of her migraines.
We also discussed with our patient performing some lab tests to indicate if there's any deficiencies correlating with migraines in vitamins or minerals, and if so, supplementing them. We also discussed certain preventative practices, for example, having a more of a balanced diet, as well as suggesting blue light glasses, which can be preventative in helping prevent some of her symptoms and reducing the eye strain, sleep disturbances, and some of the fatigue that she has been experiencing. If those holistic approaches to medicine are not effective for the patient in general, we hope to do a combination therapy with migraine medications or place more of an emphasis on medications in general.
And to address her fatigue, there is research available to show that training twice daily using a threshold inspiratory trainer while maintaining diaphragmatic breathing improves peak oxygen consumption and quality of life, which offers an accessible physical therapy model with minimal resources to address her fatigue, and can also offer a great relaxation technique as well. We'll also use graded exercise exposure while monitoring her vitals. And to address migraines, we can perform manual therapy techniques as well as postural stabilization exercises.
For holistic care in occupational therapy, we can advocate for accommodations at her workplace to manage some of the fatigue she's experiencing, change some of her routines around to try and manage fatigue and maximize when she has the most energy. We can explore coping strategies to manage stress and anxiety, and there's many options for that, just depending on what she thinks is going to be most helpful for her. And we also want to push some participation in meaningful activity like hiking and gardening.
Holistic care through nutrition. We want to ensure total body wellness through access to a balanced diet, maintaining adequate hydration. This can be both towards total body wellness and her migraine prevention, taking a daily vitamin or any supplements depending on her deficiency. And then to address migraines, it's been proven that a reduction in sugar and a reduction in caffeine can both contribute to migraine management. We can also assist in a journal to start to narrow down some of her migraine triggers. So keeping a close diet recall journal when she's experiencing her migraines will help us pinpoint exactly where they're coming from her diet. Folate supplements is also a great beneficial to migraines. And then also taking a look at the gut-brain axis through probiotics, the way that the GI system can connect to the central nervous system. Here are some resources through social work that she may have access to and find beneficial, both through support groups and financial support.
And then some of the key takeaways that we've reflected on, and then we also gathered based on what the client gave us feedback on, was to build a lot of rapport and trust, to listen and hear their stories, recognize their symptoms are real and that they're not alone in this. We want to provide affirmation, offer her some more realistic hope, and applaud them for how far they've come, as well as come up with a solid plan.
Thank you so much for your presentation. Nice to see you all again. I was the facilitator for this team. I wanted to ask you, you had a really comprehensive way of looking, a very holistic way of looking at this patient and offering help to this patient. How did the leadership work? Did you feel like you had leadership, you need leadership, or was it fluid?
I can speak to that. I think we had a lot of fluid leadership, and the fact that we kind of went in each day and whoever took the lead was the leader. And I think maybe we might have benefited from a more structured leadership system than we had, but it did give a chance for everybody to kind of speak their mind and say what they were thinking, which was nice.
I have a question about some of the dietary recommendations. How did the client respond to those? Those can be very challenging changes to make.
I can speak for that. I'm the nutrition representative, but I actually was unable to make the second session. So in the first session, she was pretty closed off to any suggestions about changing diet and very adamant that what she was doing is perfectly fine. I think upon further follow-up, I would like to maybe implement some changes or just better assess her reality, but we only had a small amount of time to work with the client. So I definitely think she could benefit from some follow-up care, but there were just other important factors to maybe entertain at the time.
Yeah. Thank you for sharing about the importance of that, taking on the nutrition related to migraines. As challenging as that is, and how much I'm sure you have to pull in a lot of motivational interviewing to make that happen for people.
I have a question. Your takeaways, the first one was to build rapport and trust. Within what groups? Is it between you as a care team, or with each other, or the care team and the client, or both?
I can speak first if you'd like, but I think we were more between the care team and the client. I mean, amongst ourselves, we definitely established trust and respect and understanding, but I think it was really important. She was a little resistant to medical teams. So we actually had a social work representation who's not on a presentation, but we established early on that she was a great bridgeway in between the medical team and the patient, and the patient was very receptive to her. She was very energetic and warm and comforting. And so we used her a lot throughout our care plan and to introduce some certain things. So definitely reading the patient, understanding their wishes, and then formulating our plan as a result, I think were sort of what we meant by that.
Yeah, I think it's a really great learning experience for you in this case, that having all of these well-meaning people can be overwhelming. And so you sought an alternative, which I think is was smart of your group, to do that, to put the patient's needs first and identify that was overwhelming. So nice job.
Are there any lessons that you would take forward into your careers as you progress?
I think one thing I definitely am gonna take with me is just to really be clear on what the client's expecting of your sessions, because I think that was one thing that I struggled with, was not really knowing when to give her a plan and when to keep interviewing and getting more information and explaining options. So I think just making sure that both the client and the caregiver are clear on the expectations of what's going to be happening and what you're going to be giving them.
I think my biggest takeaway was one of the feedback comments she made to us was that it's okay to just say I know what you're going through is hard, or just acknowledging her symptoms more instead of being how are you doing today? Oh, well, we'll get you better. Acknowledging that what she's going through is really difficult.
I have found for a lot of clients sometimes to even say, I can't even imagine what it's like, but I'd like to understand. For example, I wasn't raised in poverty. For people raised in poverty, help me understand, because that was not my experience. So, and people have appreciated it when you don't pretend that you understand what their situation is, but that you want to.
Any more thoughts or questions?
I just want to appreciate all the creative approaches, because migraines are such a hard thing, and many people's lives. So it's just wonderful that you've taken this on, and the other teams as well, to really think about this important area.
It was a very tough case, I think, for most teams to approach.
There's a lot of hopelessness, I think, that you have to be very creative around, the hopelessness that's there for people.
I found too, on a piece of paper prior to meeting the client, we had this action plan that was one way. And then when we were with the client, we sort of had to pivot based off our response to some of our action plans. So as far as key takeaways, like we could formulate this massive plan, but then at the drop of a hat in response to the patient, that can completely change and be derailed. And the direction and emphasis is now placed on a different area of expertise. So I think that was a huge learning moment for all of us. And we were able to then read her enthusiasm for a particular field and then go with the flow that way and sort of lay off a bit on the recommendations in the other avenues.
That's great. And it was probably good that you had one another, right? Yeah, at those moments.
I think there was a lot of team empathy in working on that. Swapnika, you have a word?
Yeah, I was just going to echo what Hannah said regarding reading her patient and observing her body language, the way she opened up to certain professions and closed to others, or closed to certain things, the feedback and things like that we provided. So I think that was really important to kind of support each other throughout the entire process, and being able to kind of just read the room and understand, like, okay, maybe she's not as interested in this approach, so we'll have someone else from our team to try to help her out to provide that most holistic care, like patient-centered approach that we were hoping for.
It's wonderful to hear everything that you did.
Hey, thank you so much. Great job.
Okay. Our first team is exploring the interprofessional healthcare approach to long COVID. Student team 2, the healthcare hikers.
Welcome to our project titled Exploring the Interprofessional Healthcare Approach to Long COVID with myself, Gabe, Valerie, Aya, and Stuart. Our team was composed of 2 osteopathic medical students, 1 allopathic medical student, an accelerated bachelor's of nursing student, and a doctor of pharmacy student, and a special thank you to our helpful facilitators. So a quick background, 87% of patients hospitalized with COVID do develop long COVID, and 35% of people fail to return to their jobs within 14 to 21 days of being diagnosed with COVID. And the chart on the right just shows some quick symptoms of the long COVID symptoms are just old symptoms that didn't resolve and new symptoms due to new complications.
So for our case description, we had Amanda, a 39-year-old female, diagnosed with hypertension while she was hospitalized for COVID for 11 days with ventilator and nasogastric support for 6 days, and weaned off and released 5 days after that. She has symptoms of shortness of breath, cough, and migraines that persist into 2023. She's had difficulty balancing work and family responsibilities with these symptoms. She has limited access to care in rural Maine, financial limitations, and her current medications include lisinopril, albuterol, and multivitamins.
So for our methods, our first appointment, we had 2 20-minute sessions in which all providers on the team were able to meet and build rapport with Amanda. We obtained history of her present illness, her medical history, and her priorities. And we also gave her some suggestions for headaches and for her feet issues that she could try before our next meeting. Our next meeting with her was also 2 20-minute sessions with Amanda, and this time her husband Mo was present. We followed up with the previous suggestions to see if they worked. We gathered more information about her illness to see if there were any changes from the last visit. And we worked on her SES difficulties, counseled her on her current meds, including lisinopril, and possible new medications for headaches, like triptan.
For our takeaways, we found that if we had access to a social worker and physical therapist, we would have improved patient outcomes through knowledge and access to different services. Unfortunately, we didn't have those on our team. Determining patient goals and helping them achieve those goals is very important in the setting of long-term illnesses. We found telehealth visits are essential for access to care in rural areas. Our patient lived in a rural area, but they present with unique challenges like obtaining labs and vitals. And we also found that having a spouse or other family member present during a telehealth appointment can alter the dynamic and have both positive and negative effects. These are our references. I'll now open it up to questions. Thank you.
Thank you, team, for a wonderful presentation. My name's Emily Dornblaser. I'm going to be the facilitator for this breakout session, and I'm going to open it up and give everybody that awkward pause of silence. Does anybody have questions for the team? I see some pharmacy students, and I'm not afraid to call on you. But Karen, do you have your hand up?
After 3 years of Zoom, you think you'd have a handle on this. So Stuart and others, you referenced that using telehealth has both benefits and, drawbacks when you're thinking about inclusion of the family. Could you say a little bit more about that? I think what's interesting to me about this case is not only all that we're learning about long COVID, but we're also learning about new intervention strategies such as telehealth. And so can you share with me some of what you learned was helpful and not helpful with telehealth and inclusion of families with the patient?
Yeah, I think having a family member present in a telehealth visit can be beneficial just to get another point of view and see how it's affecting the family. In this case, she was having really bad headaches. She couldn't spend time with her family or really do anything. She was pretty debilitating. So that was helpful, but I guess it can kind of get derailed with the line of questioning. It's kind of hard to like steer an interview, like with motivational interviewing. So having someone interjecting or interrupting can kind of be bad for that. Yeah.
So part of developing that rapport and being able, with your example of motivational interviewing, it's hard to execute that if you've got a third party or more interjecting and taking the conversation in a different direction.
Yeah.
Yeah. Well, I think it also illustrates how we need to practice on the education side, managing those types of conversations, because I do think that as telehealth becomes more ubiquitous and we use it more and more, we're going to have less control of those environmental interruptions that, may not support what we initially thought was going to happen in the interview.
Does anybody else have a question? I have one for the team. Just I think reflecting on maybe the previous question, one of the things as a previous IPTI facilitator I find is that when you hit a challenge with the patient, the value of having somebody else from either a different discipline or a different perspective can be really helpful in trying to tackle whatever challenge is in front of you. So I'm wondering if anyone from the team has any reflections on what maybe another profession brought to the experience that you weren't expecting or that ended up being helpful in that process. I saw you might want to respond.
Yeah, so our team was kind of weird because we had 3 medical students and a physical therapist and a nursing student. So we had a lot of like the, I guess, the medical background on the team, but we didn't have much of the social work background or the physical therapist background. So for us, it was definitely valuable to kind of, especially with the pharmacist on our team, to kind of bounce ideas back and forth and talking about her different medications and like lisinopril, how that might be affecting her. But we would have loved to have a social worker on our team to help us address those SES problems that were coming up, because that was a big part of her case as well. So I think that would have been a really great addition to our team and something that we were lacking. But I hope that other teams who did have that interaction with their social worker were probably able to benefit more from being able to learn from them and incorporate them in Amanda's care as well.
I think it really highlights sometimes when we're out in practice, we don't get a chance to choose our teams exactly. And you can this really highlights how having a really unbalanced team can actually like highlight what might be lacking in terms of helping to solve the patient's problems at hand, which is really important, I think, for all of us to be able to recognize like when to refer and when to ask for additional resources and those sorts of things. Any other questions? Folks from maybe a different profession have any curiosity about maybe some of the interventions they suggested?
We have just 1 minute left, but I'm curious if you feel like there was a really good understanding of how you managed your time with the patient and how that changed between the first and the second encounters.
Yeah, I can jump in on that. So the first encounter with Amanda, so our idea was to go in there, and we had a whole plan of what we were going to ask her and stuff, but obviously when we got in there, we found that the conversation kind of derailed. She went on tangents a lot. So we had to kind of throw out our entire plan and re-decide what we were going to do for our second 20-minute session with her. So we came in with a plan, but I mean, it really depends on where the conversation takes you and what the patient's priorities are, is what we found. Really determines on what the next appointment is going to be like.
Great flexibility. Thank you. Well done, team. We're going to move on to our next presentation.
Hi, everyone. I am Abigail Palin. I'm a second-year medical student. I was part of Team 4 during IFTI, the Compassionate Communicators, along with my 2 colleagues. And for our project, we wanted to focus on the specific learnings that we took out of IFTI rather than its value as an entire entity as a learning experience. So as you know, IFTI is comprised of 2 major sessions, each of which has a planning portion, interview portion, debrief portion, and a second interview. Our team had the following occupations: occupational therapy, physical therapy, osteopathic medicine, pharmacy, dental hygiene, podiatry, and social work. And this is the approach that we took.
So hi, I'm Stephanie Burns. I'm a first-year occupational therapy student. First, we had to decide which team members were going into the interview slots with meeting Amanda and then learning about her concerns. And then after that, we had to adjust her concerns. And then the third one was also having limited time dedicated to each concern, which was kind of a struggle for us, and then having multiple interviews that were necessary to adjust the concerns that she stated. And then with that, we had to make some revisions. So first, we had to establish our priorities of her care. So we started broad initially, and then we had to explore the options and rank her concerns in order of urgency. And then we had to develop a collaborative team plan to refer Amanda and her colleagues to the necessary colleagues as indicated. So as we followed up with her routines, we reevaluated and revised priority concerns continuously and made progress throughout the treatment sessions.
Hi, I'm Andy. I'm a junior dental hygiene student. Our main discussion during the IFTI process was extrapolating lessons learned from IFTI to practice, and those should be done mindfully of our status as students with limited knowledge and clinical expertise. Some of our conclusions throughout this was that clear and early identification of a care manager facilitated effective communication, promoted understanding, and reduced overwhelm. Complaints addressed one by one in a risk stratified way allowed for maximal progress, follow-up, and closure. And although all decision-making remained interprofessional, the best patient care was delivered on a one-to-one basis.
Thank you, compassionate caregivers.
Wonderful. I think my takeaway here is perhaps the theme of flexibility. I'm wondering if anyone on the team might want to expand a little bit on. It sounds like you guys noted a lot of needing to step back and redesign your approach to certain things. What surprised you the most about that first interaction with your patient?
I can speak to that one. I think we struggled with a lack of a cohesive plan going in. We were trying to leave things very, very open, but that actually ended up working against us, I think, because in that sense, we were trying to pursue so many different avenues all at once, when in reality, I think we would have benefited from pursuing one avenue and then adjusting as necessary rather than casting such a broad net to begin with. We found that our later approach, which was a little bit more pointed and following patient advocated priorities, that was much more effective rather than having our own agenda, trying to incorporate all of the different professions simultaneously. That became a lot to juggle and manage time-wise at the same time.
Wonderful. Mike, I see you have a hand raised.
I do. My name is Mike Sheldon. I'm the Associate Provost for Academic Affairs. I'm going to ask you a question that maybe a little bit of an extension of what your project was about. So I hope you don't view it as unfair. And I'm just really interested in your thoughts about this. How do you think artificial intelligence will help you in the future? There's a lot of publications coming out right now. It's all over the media and so forth, but there's a lot of applications that are being written about in healthcare, algorithms to help drive decision-making and so forth. And I'm really curious if any of you have given that any thought and how that may integrate into sort of your team-based work that you're doing.
I can speak to that again, I guess. One of the obstacles that we came up against kind of in our later interviews was beginning to concern ourselves with Amanda's mental health. And I think if we had been able to risk stratify that in the very beginning through some sort of algorithm that, predetermined and predicted her risk for suicidal ideation or self-harm, anything like that, that would have been a really great jumping off point, and it would have saved us so much time behind the scenes in the planning phases and actually during our interviews. So it would have allowed us to pick the most pertinent path right off the bat, I think.
Very thoughtful answer and a very, I know you weren't prepared for that one, probably.
Does anybody else have any curiosity?
I see Frank has his hand raised.
Oh, Frank. Hi.
Hi there. Great presentation. And I was wondering what you meant by the term reduce overwhelm. Was that based on you sense that the patient was overwhelmed?
I think that was a little bit of both. We didn't want the patient to feel overwhelmed with all of our different viewpoints and all of our different questions. But in the breakout rooms, we didn't want the team to feel overwhelmed with same thing, all the different viewpoints of everything. Like for me, I'm a dental hygiene major, and then we had, they were all different. But for example, social work and dental hygiene, I don't think they could be any more different. So kind of putting in our 2 cents to everything could get overwhelming at times because you just had so many different viewpoints on everything at once. And you didn't want overwhelming questions to go into the interview and then overwhelm Amanda. So I think that's what we meant by that.
Thank you.
That's a great question because I think it highlights, as you answered that, Andy, how we all bring different lenses to these patients. And when you work interprofessionally, I think one of the best things you recognize is everybody's got a lens, and it's picking which lens you might need at any given time that's best for that patient, and how to share lenses and how to trade them back and forth amongst each other. So I hope that's an experience you guys take away. I see Shelley has her hand up.
For change. So one of the myths of interprofessional education and practice is that everybody has to be in the room at the same time and interacting with the patient. And it sounds like you really did a lovely job of processing, it was a little bumpy, but processing the fact that you could work as a team, but interact with the patient singly, that worked best for the patient. So I'd love to hear just a little bit more about how you processed and came to that, because it was really a beautiful outcome.
I would say we went in, we had like a general plan. Obviously, our main goal was to help Amanda the best we could. But overall, I think we went into it kind of not knowing exactly what we were going to get out of the first interview. And that one was a little bit jumbled up per se, because we had a lot of questions, a lot of different people in there asking questions to see what the main focus should be. And then after that first interview, we took her main concerns and broke it down from there. And we didn't have everyone in the room at once. We put 1 or 2 people in just to focus on those main concerns that she had.
Great approach. Thank you so much, team. We're going to move on to the next presentation. Well done. Next up, we have student team 6, the balance beans.
1.
Our project title is Long COVID Using Interprofessional Team Immersion Treatment, and our team's name was the Balance Beans. Our team was made up of student physicians, nurses, physical therapists, and pharmacists. We would like to say a special thank you to our facilitators. Long COVID is a syndrome characterized by a wide range of health problems, including persistent headache, brain fog, fatigue, dyspnea, muscle weakness, and depression, with headache being one of the most disabling symptoms. A longitudinal prospective study out of UCLA found 30% of people treated for COVID-19 developed long COVID. The vast number of people developing this condition emphasizes the dire need for treatment approaches that are accessible to all affected individuals. However, treatment for Maine residents affected with long COVID can be especially challenging due to geographical distances between the patient and their healthcare facility. Telehealth may help overcome these challenges, as well as utilizing a multidisciplinary treatment approach.
Amanda was hospitalized in November of 2021 due to COVID. She was in the ICU for 11 days with 6 days on a ventilator. In 2023, she still had lingering symptoms of fatigue, brain fog, appetite loss, shortness of breath, and most prominently, her debilitating migraines. These symptoms have harmed her well-being, her job, and has limited the quality time she could spend with her family. Living in rural Maine has limited Amanda's access to medical care due to travel and healthcare costs.
Our methods for this study included an interprofessional team immersion orientation, a day in which we learned the rules of the simulation. We met with our team, got to know each other, and got introduced to Amanda's backstory, history, and current symptoms. Over the course of a few weeks, we had 2 different appointment dates via Zoom. Each had 2 20-minute sessions with Amanda and included a time for pre-brief and debrief amongst the team members. And each of us had individual opportunities to communicate with Amanda and to practice our interprofessional communication skills amongst individual team members.
During the first appointment, each provider was able to meet with Amanda and build rapport and get a better understanding of what concerns she had since her COVID diagnosis. During this appointment, we gathered medical history and a general health intake. Suggestions were given by PT to help with back pain, and conversations about medication treatments were discussed. During her second appointment, the physician and the pharmacist met with Amanda and Mo together, and medication counseling resulted in Imitrex being recommended for migraine treatment.
We learned via talking to Amanda and Mo that we could have sent 1 or 2 people in to gather patient information on the first meeting. For the second meeting, this is when we could have counseled. We learned that through all of the discussion with Amanda, that her goals were to spend more time with her kids and get back to work. Debilitating headache due to long COVID was preventing her from reaching her goals. We learned that time management is a key component of telehealth visits and would have managed our time differently, especially on the first meeting. Finally, we learned that having an understanding of the roles of other providers allows for good continuity of care and reduced repeated assessments.
Great
Thank
presentation.
you, team. Wonderful. Well, your last takeaway point is one that I thought I'd start a question on and then ask if others have a question. But you mentioned that collaborating with each other reduced the need for repeated assessments. And so one of the things I think is a great takeaway from IPTE is learning how folks have shared roles, not just what differentiates your profession from each other, but how you can often do the same thing and learn to trust each other and your abilities. And so I'm wondering if the team might speak to some of those experiences that you might have had, and what did you learn from each other and the abilities that you share?
Absolutely. I think overall I was really surprised with the amount of overlap that each profession had when they were initially meeting with a patient and doing their intake. And I think it's very easy to become siloed. And I think that this experience really helped us realize that we can prevent a lot of this overlap, which can be cumbersome for the patient, if you have a thoughtful meeting beforehand as a team to figure out, okay, who can ask these questions so we're not duplicating questions. So I think that was a huge takeaway that I personally got from this experience.
Yes, I can speak on that as well. I think I actually wasn't able to attend the first meeting. So after watching it back, I was able to watch the video back and take notes. And it was interesting because you could tell that the patient was getting a little annoyed by trying to answer the same questions over and over. So it definitely did help alleviate some of that in the second meeting. And it also helped, I think maybe next time if we did it again, it would be helpful to just kind of go over exactly what we ask in an intake. Because I think as a nurse, I just think I get the full assessment, but I don't know exactly what everybody else needs to grab. So I think that would be really helpful next time.
Great. Carmela?
Yeah, I really enjoyed seeing, like you were mentioning before, just like how there is that overlap between the professions. I thought that was just incredible. It was also just nice to get everyone's perspective on it. and then like seeing them interact with the patient as well was super helpful, and just to see how they would like maybe word something differently, or just simple stuff like that even was really good to see.
Wonderful. What other questions do folks have? I've got lots, so I could just keep asking you all. So I guess I'm interested, you talked about a pharmacist and a physician going in the second session, and I'm interested to hear a little bit more about how that collaborative experience took place in terms of making a medication recommendation and counseling, and how did you guys divide roles, because that is often a duplicated experience on both the pharmacy side and maybe the doctor's visit side of things. So talk to me a little bit about that.
Yeah, that was Terry and myself. So like on the second visit, we went in and we were chatting with Amanda and Mo. I don't know, Terry, if you wanna.
Yeah, I think the hardest part was kind of because we're all students learning as we go, especially with an experience like this with telehealth. It was kind of difficult, but kind of learn the roles. I think we just kind of bounced off of ideas, like you'd make a recommendation, and then the pharmacists tend to know a little bit more about medication access and price and things like that. So I think as a physician, you kind of know what drug classes there are, but there's so many different individual drugs that you can choose from that sometimes there's a lot of wiggle room in what you actually choose when it comes to generic, name brand, or even which specific medication. So I think that's what pharmacists are really good for, is knowing the details.
Wonderful. And would you guys have liked anyone else on your team? What might have been lacking?
We did not have a specific social work student, but luckily one of our facilitators, I think she was working toward her doctorate in social work. I can't remember exactly how far she was, but she was spectacular when we had a couple of questions. But we kind of originally came up with a plan before we talked to her about it. Just, wanted to make a recommendation to social work to try to meet the patient where she's at, because she did have many trepidations for that. She was very worried about meeting with social work. So it was at least nice to say, we'll, have someone reach out to you. So
thank you all. I think we're about to transition to the next presentation.
Yes, well done, Balanced Beans. For our fourth presentation, we have Student Team 8, the Healthcare Hamsters.
Hi, my name is Kim DeCarlo, and I am in the Master of Social Work program.
Hi, my name is Sailor, and I'm in the Doctor of Physical Therapy program.
Hi, my name is Victoria, and I'm in the Accelerated Nursing program.
Hi, everyone. My name is Annika, and I'm a junior in the Dental Hygiene program here at UNE. So for this spring's poster session, we decided to focus on the concept of establishing virtual continuity of care for a patient with long COVID using a multidisciplinary approach. Our group was comprised of students from both UNE and Rosalind Franklin, where we had a diverse array of professions being represented, such as osteopathic medicine, pharmacy, allopathic medicine.
And our goal was to take care of Amanda, who was a simulated patient played by a real actor. And Amanda was 39 years old and suffering from symptoms of long COVID after having COVID and being hospitalized for an extended period of time in the ICU. She is hopeful to get back to her daily routine, her life with her family, but she lives in a rural area and doesn't often have consistent access to medical management.
We believe that meeting our patient in an interprofessional setting was beneficial for meeting the patient's concerns about the financial burden of care, a lack of time to dedicate to appointments, and about receiving inconsistent care. We also believe that an interprofessional telehealth approach allowed us to provide care to an individual in a rural setting who may lack access, and for management of long COVID symptoms, which the research is still catching up with.
This slide looks at the interprofessional connections we shared in terms of each of our professional code of ethics. As you can see from the sections broken down by each of our professions, we share similarities within our ethics that focus on the humanness of those we provide care for and what we keep in mind while providing that care. This supports the collaborative approach we took, as we are rooted in common themes.
And we just wanted to thank our peer facilitator, Anik, and our staff facilitators, Frank Brooks from social work and Chris Bates Withers from PA. for helping us, for steering us through this interprofessional team immersion experience. And thank you for everyone else who has listened to our presentation.
What a great presentation. Thank you guys. I have one very important question and then we'll get to the real stuff, but which one of you got to draw the stethoscope on the hamster, or did it come like that? I thought that was great. My big question that I have for you all is, I'm so thrilled to see your slide about shared values, because one of the major competencies in interprofessional education is shared values and ethics. And I'm wondering, how did you guys come up with that slide, and what was your sharing process of figuring out what your values were? Because that is just such an important part of fundamentals of building a team, is knowing that you all have a shared place of values. So I'm really interested to hear about that.
So that was mostly Kim's idea. Kim was the one who, from social work, decided that she was going to look over every single one of our codes of ethics per program and find common similarities between all of them, and then listen together. And then the more she looked, the more we all realized that wow, even though we're different programs, we all share a very common theme, and that she was able to put it together on that slide. So it was kind of a bonding moment.
Yay.
Yeah, and I think we also saw a bit of that too when we were talking and putting the poster together. And also during our debrief sessions, we're we're all kind of on the same page here. We do kind of all have the same goals, even though we're really looking at things through a different lens.
Mm-hmm. Mm-hmm. I'm wondering, if you guys all had to pick which value you think is most important to your profession, what might you, if you had to pick one value, what would you put out there?
For my profession, which is nursing, I would probably pick advocacy, patient advocacy. That's, I think, the most important thing. And I'm not going to speak for the other professions, because I know that every other profession, including especially social work, which Kim is from, does a lot of advocating for patients. But I feel that personally, to me at least, that is our most important value.
Sure. Sarah?
Yeah, that's a really good question. I don't know if I could just pick one. I think advocacy is great as well. And yeah, I'll leave it at that for now.
Wonderful. And Annika?
Yeah, I was just going to say, I think it's really important that the patient knows that they can trust us throughout their whole process. And especially in dental hygiene, a lot of patients are embarrassed and don't visit the office regularly, or there's always different things. So just forming that connection with them, I think, is really important.
Anybody else have any questions from the audience?
Thank you. Yay, happy hamsters. Great job. I wanted to ask you a question about, yes, you came together around the code of ethics and values. Was there any tension that you had to work through, or were there areas of concern that any of you had that you thought might cause a reduction in team approach?
I personally don't recall any tension, but the only thing that I thought that might reduce the cohesiveness was that we were all from different schools and we'd never met each other before. So it's, kind of all being thrown together and saying, here, work on this. We don't really know if we have anything in common other than our professions. So that was the only, obstacle that I saw.
Yeah, jumping off of that, I would say it was I think just like any new team, kind of awkward and hard to know who was gonna kind of emerge and get the organization process started. And I think we eventually decided to have a point person, which was Kim, and she was kind of the cohesive, continuous link throughout all the visits that we had. And once we kind of decided that we could all play around her, and then it made the transitions really smooth and easy. But before, we were kind of I don't know, should we just throw out 3 random professions at a time and see what sticks, or what do we do? And I think maybe that was more of a point of just not knowing.
Yeah, I was also curious about this galvanizing around the ethics, if that was done more in your after action review as you were creating this poster presentation, or if it was integral in the work, if it was done after the experience, how do you think it would have played a factor if it was done early on in the formation of your interprofessional team?
I think if it had been discussed earlier on, it may have broken down some of the, the social barriers between us, since, we didn't really know each other all very well. But I think doing it afterward was also really important, because that's when we ended up doing it. That's when we ended up reflecting on, hey, what was motivating you during this? And then finding out, oh, we all have a very similar code of ethics.
You guys have really highlighted such an important part of team dynamics, which is not only coming at your problem from a place of shared values, but also recognizing that there needs to be a leader, but that's not necessarily the person that's doing everything. And so I'm wondering, how did it sounds like Kim became your point person, but how did you guys help her in making sure that things got done, and what was kind of your team dynamics in that role?
So it wasn't so much picking a leader as someone that the patient could have with them, so that the patient could depend on. Who could we, for lack of a better term, we kind of had to choose like a case manager, someone who can coordinate with every profession, and who the patient can have with them at all times, so they're not constantly being flung around in between different professions. So that was helpful, but I wouldn't necessarily call it like electing a leader, but it is helpful to have one person, that we all can funnel everything through before it reaches the patient.
So shared, sort of much more of a shared leadership model, but the patient doesn't necessarily see that. The patient sees the person, which I think is
yes.
We're constantly trying to put the patient at the center of everything, which sometimes makes it harder for us in the background to kind of manage and plan. But it sounds like you guys really did an excellent job of keeping the patient's goals in mind and making sure that the patient felt safe with your team and meeting all their needs. So well done. On to our last one, I think.
Yeah, this is always the fastest hour of the semester. Well done, team. And we have the collaborative Kate Buffaloes with Husna from Pharmacy, Team 3.
My name is Husna. I'm from the pharmacy. I'm in P2. Today we're going to discuss regarding interprofessional collaboration to manage long-haul COVID patient. Long-haul COVID are a wide range of new, returning, or ongoing health problems that people experience after experiencing COVID-19. In our case, Amanda, 39 years old, was hospitalized for 11 days after being diagnosed with COVID. She has been experiencing since then symptoms including decrease in her appetite and nutrition intake due to loss of taste and smell. She has been experiencing also headaches, fatigue, anxiety, and depression. We had 2 appointments with Amanda for 20 minutes each. The first one was only Amanda, in where we have to gather all the information from Amanda and listen to her concerns. And also we had to plan for a treatment goals. For the second one was Amanda with her husband, in which we engaged Amanda and her husband in the treatment plan. We discussed the treatment and answered the questions that she had. For the clinical interventions, we suggested monitor blood pressure, change albuterol to Symbicort, decrease headache, to decrease the headaches that she had, which was one of the side effects of albuterol. We suggested family therapy. For headaches, Amanda didn't want chemical-based medication. She was going for plant medication, so we suggested feverfew or Batabur. Also, we suggested to avoid non-steroidal anti-inflammatory because of her hypertension. For the lifestyle, we suggested to improve her sleeping, diet, drink a lot of water, exercise, sit in a quiet room using compression sock. For the interview with Amanda in telehealth, we used motivational interview in which we had to build a patient rapport through active listening. We used open-ended questions, respect the patient current state and express empathy, support the patient in possibility of positive outcome, support the whole family and build trust, listen to Amanda and achieve best outcome without making Amanda uncomfortable, also build self-confidence. I would like to thank the UNECC. Also, I would like to thank our faculty facilitator, Valerie, also peer facilitator, Ostasia. Also, I would like to thank our wonderful actors who gave us the opportunity to immerse ourselves into a real-time telehealth. Thank you.
Thank you, Husna, for such a great presentation. It seems like you had to cover it all. Might you tell me who else was on your team and what did you learn from those other folks there?
So I was with a nurse, I was with a PT. Also, we had a social worker, but she didn't come in, so we had to, like, every time refer to the social worker. And other thing I've learned from them is just our health program overlaps, and that's what I learned, that we when we are together, when we put everything together, we can complete each other.
Wonderful. One of the things that struck me, maybe from the pharmacy side of things, and since I know you're on the pharmacy side, was that the patient did not want medical-based care or chemical-based care. And so I wonder, that's what type of a challenge that might have been to the team, and how did the team manage that?
Oh, I didn't hear the question.
So the patient said she didn't want chemical-based care for her headaches. And so I'm interested as to how the team responded to that, and how did you come up with your recommendations?
Because our telehealth was based patient. We had to listen to the patient and give her the outcome that she wanted. So we had to do some research on medication for headaches, and we come up with the 2 medication, but about all few, and they were going also for that outcome, and because all of us, we wanted the best outcome for the patient, so we were okay with the plan.
Mm-hmm. Were there any parts that the other professions that maybe you specifically thought was a major contribution from another profession that you could expand upon?
I think every professional contributed, and if we had a social worker, that would be great, because Amanda had a lot of financial burden, and we wanted someone to connect her with all the help that she wanted.
Wonderful. Does anybody else have some questions?
I do. I'm curious if you would recommend this experience to another student in your program, or even in another program, and what you might say are the benefits and challenges of participating in this kind of immersion.
Oh yes, I will recommend this experience to other pharmacy students, and the benefit that I have learned to work with other professionals and to listen to them, and to know that I don't know everything. I have to also to contact my fellow professional health, and also the disadvantage. I didn't see any advantage in it. I saw only I didn't see any disadvantage. I only saw advantages in it.
I guess I'll ask you one more, which is, was there anything from the pharmacy side that you felt like you hadn't learned quite a bit about, that you would be interested in learning more about, that came about from this case?
I guess because I'm a P2, we are in ID, infection diseases, so we are learning COVID, and that's where it was a little bit hard for me, because it was before I learned more about COVID and long haul COVID, but I don't think there is anything I would say that we have to learn more in pharmacy, because we learn medicine and natural medicine and everything, and that's what I used my my knowledge that I learned in pharmacy on this case.
Wonderful. Well, thank you for being the solo presenter for your team. That is strong work. Well done.
Thank you.
This is a really rich discussion. Thank you for all of the knowledge sharing.
All right, so this is actually only the second semester we're running this program at FIT, and it's sort of giving a little bit of public health focus into our health professional training. And if anybody, after listening to all these presentations and wondered how you can join, and just email me. So anyway, just a little bit of overview of the program. Students actually learn a strategy, sort of a problem solving strategy in public health, and then adapt that to patient-centered care. And we want to raise awareness of public health issues. And a lot of time when you treat your patient, you're not only dealing with the medical problem, it's also, you know, looking at the entire person, the environment they're living in. It's a lot of other issues going in. So without further ado, let's welcome our first team. If you don't mind, just introduce your members before you start your presentation.
Sure, we'll go in order. So hi, everyone. Thank you for joining us today. My name is Anika Rahman. I'm an OMS2 in the Osteopathic School of Medicine.
My name is Sarah. I'm a senior undergraduate med bio major with a minor in public health.
Hi, I'm Kira. I am a first year student at the College of Osteopathic Medicine.
And just one note, if you can, feel free to turn on your video. We love to see your face.
Leaving home with broken bones, a case reflection. Our case is about a woman named Barbara Smith. Ms. Smith is a 63-year-old white female who identifies as cisgender living in Lewiston, Maine. She presents to the Central Maine Medical Center Emergency Department in Lewiston, Maine for COPD exacerbation and told the nurse she is being evicted at the end of the month with nowhere to go. Her past medical history includes seasonal allergies, an appendectomy 45 years ago, COPD exacerbation 3 times in the past 6 years, a 30-pack year tobacco use, which ceased 5 years ago, chronic back pain from an MBA 10 years ago. She uses a walker, and she has a family history of COPD, hypertension, and mental illness.
The health, behavior, social, and environmental factors within Mrs. Smith's life have all had an impact on her case. This framework gives us an aerial view of the positive and negative factors. In the red are the negative, and in the green are the positive. The complex interplay between each of these factors creates the matrix of Mrs. Smith's reality. Her most impactful negative factors included poor diet, isolated living, and food and housing insecurity. Her greatest positive factors are her faith, her church friends, and her ability to join Medicare. Our goal is to unravel these threads to minimize the negative influences and enhance the positive ones. And we will show you how we plan on doing that in the next slide.
In coming up with the solutions for Ms. Smith, we triaged the problems in order of priority. First, Ms. Smith should be admitted to the emergency department for her COPD exacerbation, and a chest x-ray is recommended as her last one was 3 years ago. Next, it's important to schedule a PCP follow-up appointment for medication management. She may need additional tools to manage her COPD given the recent exacerbation. Given the progressive nature of her chronic back pain, a PCP is best equipped to tackle a conversation about lifestyle modifications. This is to be scheduled while Ms. Smith is at the ED so that this important appointment does not fall through the cracks. OB-GYN referral should then be made for a mammogram given her heightened risk. Next is to tackle the problem of eviction and housing insecurity. This is where social work joins the team. First, it's important to understand that Ms. Smith qualifies for Medicare, and social work can help set this up. Then, it's important to provide her with housing resources. Some housing options in Lewiston include Lewiston Housing, Maine Housing, and if she qualifies, assisted living options. Utilizing one of these services can provide her with housing and the nearby resources that come with this relocation, while still allowing her to continue to stay in her Lewiston community. Social work can also sign Ms. Smith up for Meals on Wheels services so that she has a safety net for food. Next is to set up physical therapy appointments for management of her chronic back pain. This might need to wait until she has Medicare in place. Last comes dietitian counseling to help improve her diet in order to better manage her hypertension and weight. It's evident that all this will take a team to accomplish. The next time a Ms. Smith walks into an ED, consider the tools you have at your disposal, not only for acute management, but also for the patient's long-term success.
All right, we're open up for questions. Feel free to ask the team anything, their experiences, surprises, or specific to the cases. So maybe I'll start one question, sort of a overarching question. after working through the case and then looking for the resources, what's the most surprises you guys got?
I think for me it was, well, first of all, it was pretty fun to look for resources that, are very community specific. I think it made me reflect on the fact that I don't know what my own resources are in my own community. And I imagine that a lot of patients wouldn't know either. So to have someone there to kind of do that work with you is very important in a patient's care, so that they understand that, the communities they live in can give them the support they need if they know where to look for it.
That's a really critical, right? Looking for resources, because a lot of time when you're facing a patient and you only focus on their medical problem, and then, you tell the patient you need to have a better diet, you need to exercise, and then you don't know what's their environment and the why they are not exercising. And a lot of time it's not like they don't want to. There's the circumstances around them. And then when you tell people to look for resources, and not everybody even understand a lot of terms, and know where to go. Just in rural Maine, computer access, internet access, it's not always given. So knowing a little bit yourself, it's really helpful. And you know how hard it is, and certain things, it does not just come easily. So hopefully this experience will help you to help you navigate your patients in the future.
Hi, everybody. Michelle Polachek. I'm so sorry I was late. But this is an interesting conversation. I have in the past worked with family practices and pediatric practices that put together resource lists for their providers. It's not always easy to do, but it's really so helpful to have that as a provider to turn to when you have a patient who clearly needs support. So I just wanted to add that.
So great to see you, Michelle. I'd love to have more public health students and the faculty join our program as well.
Well, thank you all for listening.
Thank you. So by the way, I didn't say the program at the beginning. The case is actually sort of generated by the students. So students have opportunity to be creative, because most of the cases we use in class or we see doesn't have a lot of details. Not the medical side, but where they live, what kind of resources they have. We actually task the students to create their own case. So give the patient a location, and then they'll be able to go in to find the resources for that area. All right, so I think this is team 3. If you don't mind to introduce yourself before we start the presentation.
Hi, sorry,
go. I'm just gonna go in order, sorry. I'm Rachel Bordenaro. I'm a first year student at Unicom.
I'm Diana. I'm a part of the accelerated nursing program, so I'm just in my first semester right now.
And I'm Stephanie. I'm a second year comm student as well.
This semester, we participated in the FIT program, in which we developed a patient-centered framework for a fictional patient. With our interprofessional team, we adapted the public health problem-solving paradigm for root cause analysis and patient-centered intervention development. Our fictional patient is Mr. James Libby, who is a Vietnam veteran with a recent stage 4 colon cancer diagnosis. Mr. Libby is struggling to accept his new role as a patient because he's always perceived himself as a strong provider and does not want to be dependent on others for his care. He has an extensive medical history, which adds to the complexity of developing interventions for his case. He has a family history of colon cancer that predisposed him to developing his current diagnosis. He also drinks alcohol, smokes tobacco, doesn't exercise regularly, and recently his wife passed away as well.
This framework is intended to illustrate the various factors that impact our patient in their new diagnosis of colon cancer. We can see both positive and negative impacts that his environment contributes to the diagnosis. Here we are showing the individual negative and positive factors that Mr. Libby faces.
These are his risk factors and the things that make it difficult for him to adjust to his new diagnosis. His wife passed away from COVID. His father also had colon cancer and died from it. He receives all his care through the VA hospital only, and he has to drive himself to anywhere he needs to go. He has to deal with social stigma associated with having been in the Vietnam War, and also a recent study done found that there's a phenomenon among Vietnam veterans where declining physical health and loss of loved ones, both of which Mr. Libby is struggling with, have been associated with late onset stress that diminishes resilience and can cause further health decline.
So I'll be talking about positive factors that affect Mr. Libby's care in terms of his interpersonal relationships. He has a son who lives nearby who he can rely on for support, as well as one healthy older brother who lives in Florida. In his community, Mr. Libby lives in a quiet neighborhood and is socially active. Specifically, he attends a Unitarian church. He's a member of the Veteran Social Group and at the VA and utilizes veteran services that are offered. Also, he volunteers as a greeter at the Togus Veterans Affairs Hospital. Societal factors that affect his care is the fact that he's a white male, which means he's a part of the majority demographic group. This slide just shows an overview of all the positive and negative factors in the public health framework that we've discussed.
We wanted to make sure that our interventions were patient-specific that allowed Mr. Libby to take control of his current diagnosis and his healthcare needs. We'd like him to reach out to VA provided resources such as the Fisher House Foundation and the Hero Miles program, while also taking care of his diabetes and obesity with a nutritionist. We believe a social worker would also help him get referrals to community resources.
Anybody have any questions for the team? So I'm sure the team has looked up for resources a lot more than what they put on the slides. If you guys want to elaborate a little bit more on the resources you have fun, that would be great. Rachel, Stephanie, Diana, are you still
I
there?
think I'm confused by your question. What do you mean, like resources, as in like interventions, or resources that we use to find the information for the case? Or
I was just thinking about resources you found for the patient. As you mentioned that there's a lot of local community resources, but you can elaborate on both because that would be helpful too, knowing where to look.
Okay, I can go into that. So I am a current second lieutenant in the Air Force, and I also volunteer at Togus every now and then in Augusta. That was part of the reason why I chose this case. So Fisher House Foundation is a resource that the VA and the military provides to veterans. That is a house basically right next to VA hospitals that allows their families of veterans to stay at while their family members getting care at the VA hospital. And then the other one that we mentioned was Hero Miles program, and that's another military funded program that would allow Mr. Libby, our patient, has a brother that lives in Florida, so it would give his brother the miles to fly from Florida to visit him in Augusta. And both of these programs are available to the veterans that utilize the VA hospitals. And then outside of those, we also talked about consulting a nutritionist or a dietitian to modify his diet. He lives in Augusta and he is able to drive himself, and he lives about 5 miles away from the closest grocery store, but we want to make sure that when he does make it to the grocery store that he's choosing the right food options for his diet or for his health needs, and then also connecting him with a social worker to help with transportation service if that becomes a future problem for him, since he is an older individual and things are pretty far away in Augusta. They're not like it's not a very condensed city. And then also probably to consider meal or grocery delivery services that Hannaford does provide. And then since he does suffer from PTSD, maybe a psych evaluation would be beneficial for him to, come to terms with that reluctancy that he has, or that negative outlook he has towards healthcare and getting healthcare services done for him. And then also a colon cancer support group. There are plenty online and that we could find for him either locally or nationally that are, very active. So those were the options that we came up with for him.
This is great. So Rachel, do you want to add where you guys start to look for the resources for your patient? From the hospital website or any public links?
There were two case studies that Stephanie had found in different databases that I went into, and I looked at specifically what the the HPI looked like for those two cases, and then I based the HPI for our case around that, and kind of the symptoms that I read based on those two case studies, I kind of like combined them together to get our fictional patient's HPI, so that I had a realistic kind of, because I don't know much about having stage 4 colon cancer, so I just wanted to make sure that it was an accurate representation of what someone who has stage 4 colon cancer would be experiencing as they're going to get diagnosed with it.
That's great. Michelle, I don't know if you want to chime in. I know you worked with Hannaford about the nutrition program.
Yeah, so I have so many thoughts running through my head as I'm listening to this. It's such a complicated issue, and chronic disease is so clearly underlie, I mean, nutritional issues underlie most of our chronic diseases. So Hannaford has a lot of resources for patients. I don't know if you're aware, but they also have all these virtual resources available for folks. Not only do they have dietitians in their stores, but then they have cooking classes and all other types of virtual resources available for anyone who just wants to tune into those. And I didn't even know about half of those resources until recently. They also use guiding stars. It's a shelf tag labeling system, which helps shoppers make healthy choices without reading labels and that sort of thing. So it's pretty easy to make healthy choices at Hannaford. But I'm wondering too about medically tailored meals. I know that someone going through stage 4 colon cancer treatment is going to have specific, dietary needs and issues beyond just, thinking about preventing colon cancer. So once somebody already has colon cancer, we know that there are lifelong habits that have gone into sort of creating the underlying nutritional deficiencies that may have contributed to that. And so changing those things is complicated and takes years of practice and hard work to sort of, and his wife just died, right? So who's cooking for him? So I'm sure the dietitian will address some of these issues, but medically tailored meals is something that has been really, really helpful for people in this type of position where, if they can have a delivery service deliver some meals. And there are some resources around in some demonstration areas around Maine. And I don't know if one of them is in Augusta or not, but that would be an interesting resource to investigate.
Thank you. I think the team got more tasks. This is a really useful because, in Maine, from a last census, 11% of the population is veteran. So if you're planning on practicing in Maine, you're going to encounter a lot of veteran as well. So thank you. I see some names.
Hi,
here.
everyone. So my name is Deng May. I'm a first-year comm student.
Hi, my name is Macy Punzalan. I'm a third-year dental medicine student.
And my name's Alexandra, and I am a second-year physical therapy student.
So today we're presenting for the public health interprofessional training, and our case is a patient with stroke in rural Maine. So Antonio Garcia is a 54-year-old Hispanic male construction worker who presents with right-sided MCA CVA secondary to macrovascular diabetes complications.
So here's our case framework. We have the individual, family, friends, community, and environment factors. On the left, we have the risk factors. On the right, we have the protective factors. And for there's many factors involved in this case, but our main focus on the one that highlighted, and we will have intervention that interrogate those. We have the modifiable for individuals, including high-fat diets, limited exercise, and some comorbidities, and other demographic. And we also have demographic and socioeconomic status factors, such as he's Hispanic, he's only have community college education, and he's low income. And for family and friends, he has a chronic ill mom that require a lot of caregiving, but he has no siblings to help around. In community factors, we have he has a dental office close by, but the hours is limited, so he doesn't get to see the dentist often. And he also has previous negative experience in healthcare, so that hinder him from seeking for help. And there's this, the closest stroke specialty clinic is important, so it's quite far away. And the entire family only have one car, so it's hard for him to get around, and there's no public transportation accessible.
So potential interventions that we came up with was to first limit the cost of healthcare for him by utilizing telehealth, patient portal messaging, direct primary care options, and dental therapist options. We want to limit the cost of his prescriptions through resources in the community. We want to get a dietitian or nutritionist to provide resources to learn more about a well-balanced diet and exercise. And we want to set up social work connections to discuss his previous negative experiences with healthcare and connect him with state resources such as long-term disability to help make up for the lost income since he won't be back to work. We also want to have him set up with home health nursing for both himself and his ill mother, and then set up with an RTP United Way ride system to help him get to his doctor's appointments or the grocery store. And that is our framework.
All right. Thank you for the presentation. Actually, your team is somewhat unique out of the 4 team. You are the only one that has a dental student in our team. So I would like to, ask from both sides. Students not from a dental program, how do you feel working with a dental student? And then Macy, how you feel with working with the other health profession. You are the only case actually had a dental issues listed for the patient.
It was super cool working with a dental student because she brought up a lot of really good points in our case. And, I think that a lot of the stuff that we came up with, she was able to tie into dental health and dental medicine. So it was really rewarding.
I enjoyed seeing how our professions could overlap in care. So it was really great working with everyone from other professions as well.
And I'm sure you all know that dental issues could lead to cardiovascular issues. So now you actually get connected and work on this. One thing I do want to ask you, Macy, how do you know which town has the water that already fluoride treated? Is that something as a dental student you would just know?
So we actually had to look up different cities and if their water was treated with fluoride. So we made sure that his city was. Yeah.
Mm-hmm. So there is a public resources that people could find out.
I'll ask a question. I was impressed with your attention to cost, with your attention to really thinking about how this gentleman was going to be able to not only navigate the medical aspects of what he was dealing with, but the cost as well. And I also noticed that you were not scrimping, so to speak, on the quality of the care you were putting together for him. So it made me think about something called the triple aim, which is out there in the universe. And I'm wondering if that was something you considered when you were conceptualizing the case, as well as the broader public health schema that you put together. Was that too complicated? Anyway, just respond however you'd like.
I'm not sure how to answer that question, but in terms of the quality of care that we developed, when developing this case, we realized that we had developed a really unfortunate case with a lot of health disparities. And so I think a big challenge for us was researching these different assistance programs for, people who aren't able to afford their prescriptions or don't have access to a good, inpatient rehabilitation hospital for stroke. So, in terms of like the quality of care, I think that it was really rewarding to all of us to, find these programs that we usually wouldn't, think to look at. So I don't know if Jenny has anything else to add, or Macy.
Yeah, just for our patient, because we do have a lot of like risk factors for him, but in general, he has good family support. So our main focus just shift from the relationship stuff and to like the care, what resource we can give him, and what type like resource to decrease the cost for him, all that. So I think we did a good job. Is we try to put different aspect from the dental aspect, from like physical therapist aspect, also like even for the relationship between him and the doctors, because he has like negative experience with other physicians that like he didn't want to seek for help, and that's also a main focus for our case.
Really good. I know we have to move on to the next case, a presentation, but I just want to kind of leave a question for the audience. Compare the last case and this case. Both are, older gentlemen and have health issues, but they have a very different sort of a characteristics. They're different a race, ethnicity group, and a different living environment and different resources, even the insurance, one had a TRICARE and the one only have a MaineCare. So just kind of leave the question for the audience to think about it. When you see the patient, the medical problem is not the only problem. There are a lot of issues you have to look into and to think about it. All right, we can move on to the next presentation.
We also have an extended discussion at the end of this. So Mike Chilton, I saw you raised your hand. Definitely hold on to your question for the end when you can ask any group about questions you had throughout the discussion.
Yep. Great, Megan. So team 4, if you would like to introduce yourself before we start the recording.
Hi, my name is John Kaminsky. I'm a physical therapy student.
Hi, I'm Kaylee Dixon. I am an osteopathic medicine student.
I'm Camille Mulcahy. I'm also a comm student.
I'm Lacey Reed, and I'm an undergraduate public health major.
This case is brought to you by the following students as part of the Public Health Problem Solving and Interprofessional Teams program. In this case, we will discuss the management of a 56-year-old male 3 days post-stroke, as well as some other complications regarding his case. In this presentation, we will discuss the patient's background, a variety of risk factors, protective factors, and the interventions designed to address his impairments, as well as the healthcare team required for those interventions. This is a visual framework we will use to organize this case. As we proceed, we will populate the boxes with the information that we discuss so we can visualize the relationships among the factors of this case.
Mr. Lopez is a 56-year-old Hispanic male living in Portland, Maine. He was brought to the emergency room by his neighbor where he presented with left-sided weakness and dysmetria, left eye ptosis, and impaired balance with asymmetrical posturing. He was admitted to the stroke unit for 3 days and then transferred to inpatient rehabilitation. Mr. Lopez has been laid off from his job as a nighttime security guard due to his hospitalization and residual effects of the stroke, including left side impairments and movement deficits. His wife passed away 2 years ago due to surgical complications and has one child that lives close with whom he has a good relationship with, and one child that has moved away. His father passed away at age 60 due to a stroke, and his mother is living in an assisted living facility where he visits her approximately once a month.
For Mr. Lopez's risk factors, we first began by identifying those that were related to his health status and determining which were modifiable versus those that were not modifiable. For modifiable health status, he had a history of obesity with a BMI of 32, type 2 diabetes, hypertension, hyperlipidemia, and obstructive sleep apnea. These conditions are all able to be managed via compliance with prescribed medications, diet changes, and regular follow-up with appropriate providers. He additionally reported a diagnosis of depression, which onset 2 years ago following the death of his wife. This is also a health status that can be managed via prescribed medications as well as therapy as needed. The aspects of Mr. Lopez's health status that were not modifiable included his age of 56 years, as well as his family history of stroke. Next, we evaluated Mr. Lopez's risk factors in regards to his behaviors. Our assessment concluded that his diet consisted of mainly fast food, and he was a regular tobacco user with a 40-pack-year smoking history. He additionally reported alcohol consumption primarily on the weekends, however described heavy consumption at 6+ beers each day during the weekend. Mr. Lopez also reported that he lacked any regular exercise routine, including light activities such as walking. These are additional risk factors that will need to be addressed as our team continues to work with Mr. Lopez.
Some of Mr. Lopez's risk factors within his working and living conditions include recently getting laid off from his job. His highest education obtained was his GED at age 28, and within his local neighborhood, it's considered less safe conditions for walking. Mr. Lopez's protective factors within his personal include insight of health concerns triggered by his recent CVA with new motivation. He has access to a vehicle, and he has history of physical activity. Within his social protective factors, he has a healthy local son able to assist. He has a supportive neighbor. And within his environmental protective factors, he has public transit available, a nearby grocery store, so access to healthy food, and an elevator in his apartment.
The healthcare team will be focused on the following interventions: acquiring main care coverage, assess expected functional outcome, and establish appropriate discharge plans, the coordination of social resources for discharge, monitoring of vitals, physical and occupational rehabilitation and education, pharmacological consultation, mental health screening, substance use counseling, securing unemployment benefits, and dietary education. The healthcare team will consist of the following professionals: this team and Mr. Lopez thank you for your time and attention to this brief discussion of Mr. Lopez's case.
Very impressive presentations. All right, we're open up for questions.
Okay, so very nice job. The others did a great job too. So I am wondering whether you had considered, since social activity is such an important protective factor, whether there might be a way to connect Mr. Lopez to some virtual activities, since he is kind of, has limited mobility, although he does have a car, et cetera. I mean, with his wife being deceased, I'm wondering if there might be a way to connect him with activities that might be fun for him.
Well, that isn't something that we had considered. That is interesting, especially considering how difficult transportation would be, having to move around the bus schedule and whatnot. Yeah, we'd have to know what his internet access was like, whether or not he had internet access at home, public availability of internet. I know that some downtowns have free Wi-Fi. Public libraries are also an option, either for Wi-Fi or use of computers at their facility. So it definitely would be probably fairly easy, if you're looking to engage in some sort of online community. Just finding time to get down to the public library, if that is the only available option, is certainly possible with the public transportation system. So it would have to definitely depend on how important that is to Mr. Lopez, as well as whether or not there are communities online relevant to his interests, which there probably are, because the internet's kind of big.
It is kind of big. I noticed his depression as recent onset of depression, so I thought that might be a way to help.
Good afternoon, team. I have two what I think somewhat related questions. My name is Mike Sheldon. I'm the Associate Provost for Academic Affairs. I'm curious, in your plan, you had monitoring vitals, and I'm wondering about your thoughts on the use of telemonitoring, not just the vital signs, but other things that you have in your plan. And also, the team is a pretty big team because this is a fairly complex case. Your thoughts about the platform, communication platform you'd be using to help facilitate really good coordinated conversation between the team members going forward.
With respect to the vital monitoring, I think our thoughts were mostly in inpatient care. You'd need monitoring of vitals in order to facilitate the administration of care from other providers, just to make sure that you don't cause any vital system failure or complications otherwise. But if anybody else has anything to add regarding vital monitoring at home, that would be interesting. I know that it is possible. I've heard from some nurses that do this sort of thing.
When it comes to vital monitoring at home, I do think it's an option. I think that in order to accurately do that, we'd need to teach Mr. Lopez how to accurately take his blood pressure, because I know that some of the at-home blood pressure cuffs can be, depending on who's using them, you have to give them that education because they can get false readings, and then that can cause stress to them, and that can go down a whole different pathway. So I think just the main thing with that would be educating the patient on how to properly do it, considering them like sitting down, not after they just walked upstairs. They need to have like rested. Anyone else have anything to say?
So what about a team communication? The second question.
I mean, off the top of my head, I'm thinking phone calls, email. I'm not sure exactly what would be different in this sort of situation. I know that if there was home care provided, some co-treatments would be possible so that you'd be able to communicate at the site of care. But if anyone else has anything to add, I'd be interested in hearing that. Also, if someone asking the question might be interested in maybe explaining some of their thoughts.
You do have a case manager, right, in your team. So you probably the case manager would be a somewhat a team leader in your care team, and you would have regular schedules, I think, for meetings, reportings, and all set up all those kind of structures for the care.
And I don't mean to put him on the spot, but I'm going to put Dr. Muser on the seat, because he's worked with, and I have too, a little bit, with a company that actually does some of this remote monitoring and helps to coordinate transmission of information and sends up flares. To the point about the blood pressure readings, if there's an irregularity over time, it sends a flare up. And it contacts to the appropriate provider who might need to know that. So Tom, I don't know, in a quick snapshot, if you could speak to, I know you know what I'm speaking about, but if you could just give a couple of comments about that.
Thank you, Mike. Yeah, you're referring to something called Sensio Systems, which is a organization that really attempts to, on a specialist monitoring level, kind of help primary care providers do a better job through digital monitoring of their patients in their homes. And so the patient must agree to have this monitoring system installed and learn how to use it. But the benefit is that it catches things early. And it's not that the care is provided by Sensio, but they facilitate care then provided by the regular clinician. So this kind of monitoring, I think, is going to be really interesting as it is linked to artificial intelligence, which might notice patterns even sooner than a clinician might. So anyway, I hope that helps.
Do we know any of these system being covered by insurance, or this is a main care? Would it be cover some of these services?
I know Sensio has found a way to bill for services, but I couldn't give you specifics on that.
Mm-hmm. Yeah.
And I do believe that Medicare does cover a fair amount of RPM in terms of sending patients home to do self-monitoring.
Mm-hmm. This is really good to know. And I think this is also going back to patient-centered care. A lot of the things as a provider, you might not know what resources are available or not available. And to really care your patient, not just suggesting things that has to be done, but also help to find out how this can be done. I'm sorry. We're in the open question phase, open discussion. So anybody have any remaining questions and comments, just feel free.
I'd like to just deviate a little bit from AI, if that's okay, Sheldon. I know Dr. Polachek brought up also the behavioral health component of this. This is a gentleman who is experiencing at least what seems to be situational depression, but I also notice in your list of interventions, you talked about substance use counseling. And so I have a question about cultural considerations in working with this gentleman around mental health, substance use interventions. Is there some thinking that went into the cultural aspects of working with him?
As far as I know, we didn't really think about any sort of cultural considerations. That was just one part of this case that we didn't really develop, sort of. But I think as long as you approach something like that in a very open-ended sort of way, any cultural considerations or barriers or other factors will reveal themselves in, for example, a motivational interview style of, you know, we've noticed you have these sort of habits, and I want you to know that these are things that can impact some of these outcomes. Is that something that you'd like to talk more about? Because we can consider this, this, this. Do you have any interest? And if they don't, you could ask why. If it's a cultural reason, that'll reveal itself. Otherwise, yeah, we can proceed. So I think that with the right amount of openness, you don't have to necessarily prepare for all possibilities, and cultural considerations being one of them. It's just about being open and being comfortable asking why, and maybe also just being comfortable with not having some answers for things.
Maybe team 2 want to chime in as well. So both of your patient has a Hispanic origin. And also I remember one of your cases, the patient did not want to go to the doctor because the doctor does not speak their language, had hesitation to get regular care.
Yeah, so for us, our patients primarily speak Spanish. He went to community college and get some like language training, but like he still prefers speak Spanish. So for him, our focus will be like using a interpreter, like an interpreter, as have someone help to translate throughout the process. Also, like we need to know how well can he communicate online. How can he type out the English word? Can he like communicate on phone? So those will be the aspect we need to all consider it.
So one question I want to ask all team members or anybody here. So in our program, we mentioned that Maine has a 211 you can dial and to get resources. I don't know if anybody have tried that to help your patient to get resources, or anyone else have any comments about 211. If you ever used it or have any experience.
I've used it personally, and I've been a primary care provider for 10 years. And unfortunately, I think some of the funding for it had decreased maybe about 3 to 4 years ago. But it's still a solid place to start if you really have no idea where to go. And my hopes are that line will get more robust again. When I first started, it was very robust and there were a lot of answers. And then, like I said, around 3 or 4 years ago, it kind of declined a little bit, but my hope is that will turn around.
Thank you.
So I've been asked to say that we're come to the end of this amazing poster session. Thank you, students. You are amazing and you give me such hope for the future. Thank you so much for your fine work. For attendees, thank you for being here. And for those of us who are part of this roadshow, we're going to meet back in the main room in just a minute. So thank you all so very much, and have a great day.